Well, welcome to part 3 of our discussion of Alpha-1 Antitrypsin Deficiency. My name is Jamie Stoller. I'm a pulmonary critical care physician, a member of the Respiratory Institute at the Cleveland Clinic, and I serve as the chairman of our Education Institute. And I'm delighted in part 3 of this discussion to present information about diagnosis of Alpha-1 Antitrypsin Deficiency, as well as specific therapy of Alpha-1, so-called augmentation therapy, in which we'll review the evidence that supports and perhaps leaves in question the efficacy of augmentation therapy. Now, we talked about the clinical features, and I'd like to suggest that the following clinical features should suggest or prompt suspicion of Alpha-1, such that these individuals should certainly be tested for Alpha-1, every one of them. Patients who present with pulmonary disease, either of early onset or of emphysema in a non or trivial smoker, or with a chest x-ray of the sort that I'll show you, which has a characteristic basilar predominant hyperlucency pattern, or patients who have a family history, remembering that this is an autosomal codominant genetic condition. Patients presenting with liver or lung disease in the family should all be tested. Actually, as the guidelines, as we'll discuss, suggest, every patient with fixed airflow obstruction who's symptomatic should be tested for Alpha-1 antitrypsin deficiency. From a liver point of view, patients who have chronic liver disease that's otherwise unexplained should be tested for Alpha-1 antitrypsin deficiency with a serum level, in my view, and a phenotype or genotype. I'll discuss that in just a few minutes. Patients who present with this unusual dermatologic manifestation of paniculitis should be tested for Alpha-1 antitrypsin deficiency because this is clearly associated with Alpha-1 antitrypsin deficiency. And patients who present with vasculitis of the granulomatosis with polyangiitis type should be tested because of the association that's demonstrated between Alpha-1 antitrypsin deficiency and this vasculitis. This is the classic X-ray of an individual with emphysema due to Alpha-1 antitrypsin deficiency. And while classic, it certainly represents the minority of such X-rays. But you'll notice that it clearly shows the manifestations of emphysema, hyperinflation, flattened diaphragms, small heart. It shows hyperlucency, that is to say the lung is darker than it should be because of the absence of parenchymal markings. And you'll notice that in this case, that hyperlucency seems to be greater at the bases, the bottoms of the lung, than at the apices of the lung, which is an unusual pattern, not usually seen in usual cigarette smoking acquired emphysema, in which the changes are more commonly apical than basal. To give some more appreciation of this, if we look at a CAT scan of a patient that I followed with Alpha-1, here's the apical cut. One sees the trachea in the middle. On your left, the patient's right side, as the patient is lying face up with the head away from the screen and the feet towards us. And on the left side, on the opposite side, the left lung. The right and left apices are not absolutely normal. There is some loss of lung parenchyma, but that loss of lung parenchyma and the bullous changes are nowhere as pronounced as they are at the bases of the lung in this individual, where you can see that these large blebs and bullae are characteristic of emphysema, are loss of lung parenchyma. So again, this basilar pattern. One sees another example of this in another patient that I followed for some time, whose apex is relatively preserved, although this individual has an FEV1 of about 25% predicted. Nonetheless, the base of this individual's lung shows the obvious changes of emphysema with big holes or blebs and bullae that are characteristic of changes of emphysema. We know, again, from the work of David Parr and colleagues in the UK, that this pattern of basilar hyperlucency on CAT scan describes about 2/3 of such individuals, but about 1/3, 36% in that series of individuals, may have the conventional upper lobe predominant disease. So the absence of lower lobe changes doesn't rule out the diagnosis, as is suggested here. Now, I alluded in our first conversation to the ATS-ERS, the American Thoracic Society, European Respiratory Society guidelines, in which a group of thought leaders came together, conducted a systematic evidence-based review of the literature, and offered recommendations for testing. And in this case, what I'll present to you are the level A, that is to say, these are the recommendations that should be followed. We suggested, because I was privileged to participate in this document, that all symptomatic individuals with persistent airflow obstruction on pulmonary function tests should be tested once for alpha-1 antitrypsin deficiency. Whether they're characterized as having emphysema, chronic bronchitis, COPD, or even if they're called asthma, as long as they incompletely reverse on bronchodilator testing. Such patients should be tested for alpha-1 antitrypsin deficiency with a serum level, as I'll discuss, and a genotype or phenotype. In addition, asymptomatic individuals who have persistent airflow obstruction, who may have smoked or have occupational exposures, should be tested for alpha-1 antitrypsin. All such individuals. Individuals with unexplained liver disease should be tested for alpha-1, whether they're newborns or adults. Individuals with necrotizing paniculitis, because of the demonstrated association with paniculitis, should be tested. And finally, because this is an autosomal codominant genetic disease, the siblings of individuals with known severe deficiency should be tested. And we know that testing all family members of individuals who are either homozygotes or heterozygotes will clearly identify a higher prevalence of abnormal individuals. So again, because this is a genetic disease, you're not only treating the patient in front of you in your office, but conceivably, potentially their parents, siblings, and children, all of whom are at risk of having this genetic predisposition. Now, how to test for alpha-1 antitrypsin? One may do serum tests for the level of alpha-1 antitrypsin in the blood. This is characteristically done by a turbidimetric method called nephelometry, in which the normal values, of course, they vary from lab to lab, but are roughly in the 100 to 220 milligrams per deciliter range. That, for example, is the normal range here at the Cleveland Clinic. Using the micromolar nomenclature, those values translate to 20 to 53 micromolar. And it's important to recognize the units on the diagnostic test, because obviously 20 micromolar is normal, but 20 milligrams per deciliter would be highly abnormal. So it's important to pay attention to the units of the test one's using. Phenotyping refers to determining the alpha-1 antitrypsin protein type by using identification of the different alleles, in particular with a method called isoelectric focusing, in which the alleles migrate, or the bands migrate on an isoelectric field and separate, and by recognizing the patterns of those bands, one can identify the particular allelic variation, MM normal, ZZ highly abnormal, or other variants as noted. Finally, there's both genotyping, which looks for specific alleles using DNA probes, most commonly of the S and Z type. Occasionally there are F probes as well, another allelic variant, or in fact gene sequencing. The gene probes use a PCR or polymerase chain reaction, and one may do direct gene screens, if you will, or genetic DNA sequencing. Now, there is available through funding from the Alpha-1 Foundation a trial called the ACT, or Alpha-1 Coded Testing Study. This allows patients to be tested confidentially at home at no cost to them. And let me describe this, because this is a mechanism that can be used and can eliminate financial impediments to making this diagnosis, as well as concerns about genetic discrimination, albeit illegal. This is a confidential home dried blood spot test that is performed at the University of Florida by Dr. Brantley and his colleagues, again, in collaboration with the Medical University of South Carolina and funded by the Alpha-1 Foundation. This will result in the communication to the patient of a serum level of alpha-1, as well as their genotype with the presence of the S and Z allele. There is, again, no cost. The tests will arrive at the patient's home on signing up for this study online through accessing either the Medical University of South Carolina or the Alpha-1 Foundation websites as shown here. And one can receive a card with a lancet and a test kit. One would fill those blood spots with small circles of blood, put the identifying information, send it to those labs, and the results would come back to the patient confidentially, not to their healthcare provider, but to the patient, him or herself. And again, this is performed and returned to the patient. This is the literature that describes this important study. This is a study that was used, for example, in the studies in which respiratory therapists were able to recommend testing that I described in part 1 of this series. Now, we do know that despite these guidelines suggesting testing uniformly for all patients with COPD, that the results from this study by Grulich and colleagues, even in 2013 suggests that it's a minority of doctors, at least in this survey from Germany and Italy, a minority of individuals who you can see in the first row report testing all COPD patients for alpha-1 antitrypsin. Only 18% in Germany and 25% in Italy, as shown here. And so there's clearly an opportunity to enhance diagnostic testing and therefore recognition, as we discussed in part 1. Now, a few closing words about therapy for alpha-1 antitrypsin. Of course, the deficiency. Of course, these patients are treated with COPD with all the usual modalities for treating such patients, with bronchodilators, where appropriate, inhaled corticosteroids, influenza and pneumococcal vaccination, pulmonary rehabilitation, where indicated, supplemental oxygen, and so on. These are the conventional therapies. The one thing that we do recognize, not to be discussed here, is that results from the National Emphysema Therapy Trial suggest that individuals with alpha-1 antitrypsin deficiency and emphysema tend to do worse with lung volume reduction surgery than do COPD patients in general, particularly if they have heterogeneous emphysema and low post-rehabilitation exercise capacity. So in general, we do not, in my practice, recommend lung volume reduction surgery for such patients with alpha-1. Augmentation therapy is the only specific therapy currently available for these patients, and this involves the infusion of pooled human plasma-derived alpha-1, which comes from large populations of blood donors from whom the alpha-1 is purified, extracted, and then reconstituted and infused intravenously, rather like giving insulin to diabetics who lack insulin and therefore given insulin as a way of offsetting that deficiency. Now, the efficacy of augmentation therapy is the continuing source of discussion and has been evaluated in two ways, both biochemically, in which we look for evidence that the infusion of the drug raises the serum levels above the protective threshold value that we discussed. And we'd be wanting to see that the infusion of this drug at a certain dose, any of these drugs, 60 milligrams per kilogram, body weight is the suggested dose, that one would raise the serum level from below to above the protective threshold value for the duration of the dose. And that we want to be assured, of course, that the infused protein preserved its functional activity to bind neutrophil elastase to protect the lung. Perhaps more important are the clinical efficacy criteria, in which one would be expecting evidence that not only does the infusion of the drug preserve the serum levels above the protective threshold value, the biochemical criteria above, but more importantly, that in doing so, one protected the lung against progressive emphysema, enhanced survival, enhanced quality of life, and of course, perhaps made the patients feel better, fewer exacerbations, those sorts of criteria for clinical efficacy. What do we know about the results of various studies that have examined these criteria? Biochemically, as shown here, we know that the drug has biochemical efficacy. All 4 of the available drugs approved in the United States, and this has been variously approved in other countries, but today there are 4 such drugs available in the United States, all of which have been approved by the Food and Drug Administration on the basis of biochemical efficacy. The first such trial by Weavers and colleagues, published in the New England Journal now many years ago, showed that in individuals who started below the threshold value, who were severely deficient as shown on the left, whose values fell below the red line of the protective threshold, when given 60 milligrams per kilogram once a week, their serum levels as shown on the vertical axis in milligrams per deciliter on the left and in micromolar on the right, their serum levels rose and then declined with a serum half-life of 3 to 5 days, such that at the end of the dosing interval at 7 days, the serum level was at or not slightly above, particularly with progressive doses, the protective threshold value. So biochemically, the infusion of augmentation therapy does raise the serum levels, does preserve the functional activity of the protein, and can do so progressively over time. When we look at the evidence with regard to clinical efficacy, the results are somewhat more controversial, but overall, in my view, supportive of efficacy. There are 3 large observational studies, the largest 2 of which were conducted by Searsholm and colleagues and the NHLBI registry that I've discussed earlier. A third paper by one of my colleagues, Adriano Tonelli, then at the University of Florida and now at the Cleveland Clinic. There are 3 randomized trials, 2 of which have been published, one of which at this presentation is still in preliminary communication as an abstract at the American Thoracic Society last year. And the randomized trials have looked at outcome measures of CT lung density as a measure of emphysema progression as well as FEV1. I want to summarize overall the results of these trials rather than showing you the individual data elements. But taken together, the results of these studies suggest the following conclusions. That in the large observational cohort studies, the Danish-German study by Searsholm and colleagues, the NHLBI registry conducted at 37 centers throughout the United States and Canada, augmentation therapy recipients, again not randomized trials, experienced a slower rate of FEV1 decline than did non-recipients. And in the NHLBI registry, survival was higher among augmentation therapy recipients than not, although there may have been other cofactors, socioeconomic status, et cetera, that biased that interpretation. This effect of slowing the rate of FEV1 decline in all of the available studies was most pronounced among individuals whose lung function was in the mid-range of airflow obstruction, what we might call GOLD stages 2 and 3 by current parlance. This was not, these staging systems were not yet described when the registry was reported. As I said, in the NHLBI registry, augmentation therapy recipients experienced improved survival. In 2 of the 3 randomized trials, the 2 that have been published, both with Asker Dirksen as the first author, the second of which was called the Exactly study, augmentation therapy recipients did not, in fact, experience a slower rate of FEV1 decline, but in this hypothesis-generating study, did, in one of the 4 analyses, did experience a slower rate of decline of lung density on CT, again, a measure of emphysema progression, probably more sensitive than that of FEV1 decline. In the preliminary results of the so-called RAPID trial that were presented by Dr. Chapman at the American Thoracic Society in 2013, again in this randomized controlled trial, there was a trend, using a one-sided t-test, a trend towards lower rate of lung density decline among augmentation therapy recipients. In the open label crossover arm of that study, again preliminarily presented, there was an inflection point and a suggestion of slowing of the rate in those patients who crossed over from placebo to augmentation therapy. So in aggregate, the result of these various trials, although none of them in my view is independently definitive, the weight of the evidence taken together clearly suggests, in my view, the efficacy, clinical efficacy of augmentation therapy. And when the guidelines, again returning to the 2003 American Thoracic Society, European Respiratory Society guidelines were published, taken verbatim from that document, we as a group suggested the following recommendation. Recognizing that supportive evidence of efficacy comes from concordant observational studies, but not from a randomized controlled trial, not a definitive one, the task force recommends intravenous therapy for individuals with established airflow obstruction on the basis of Alpha-1 Antitrypsin Deficiency. Importantly, the evidence was clearly strongest for individuals with moderate degrees of airflow obstruction than for those with severe obstruction or less impaired airflow, although emerging data suggests that there may be benefit for individuals in the severely impaired group as well. Clearly, augmentation therapy is not recommended for individuals with no evidence of emphysema whatsoever. And again, the benefits in groups with more severe or less severe degrees of airflow obstruction than GOLD stages 2 or 3 by the older GOLD criteria was less clear from the available evidence. Now, this is a rapidly evolving field. Again, everything that I've described to you in the last 3 sections of this talk have been described in 51 years. And so the pace of research and the pace of discovery and the prospect of new therapies are very much in evidence. And when we look at exciting new opportunities, there are studies underway with regard to new routes of administration, new agents. There's information about neutrophil elastase inhibitors, about that are small molecule oral agents. Exciting work from the laboratory of Dr. Lomas and colleagues about preventing polymer formation by inserting proteins into the Z molecule and preventing polymerization. There's protecting elastin, Their approaches using hepatic secretagogues, largely disappointing to date, using 4-PBA or 4-phenylbutyrate. And finally, there are exciting studies underway today on gene therapy, most commonly using an adeno-associated virus as a vector to transfect normal human tissue, the human tissue of individuals affected with alpha-1 antitrypsin deficiency with the normal gene. The murine studies that were done as the basis of these human studies are quite promising. The human studies are underway. And so my expectation is over the next decade or less, we will have the emergence of new therapeutic options that creates, again, an imperative for the recognition of these individuals. Let me close with a case report for you, a case study. This is not a HIPAA violation. These are individuals in a family support group. Some of them have alpha-1, some of them don't. You can't tell who's who, and that's the point. And of course, the question that's plagued medical historians for decades has been the question of whether the famous composer and pianist Frederic Chopin, was he the first individual with alpha-1 antitrypsin deficiency that went unrecognized? Let's consider the evidence. You take his medical history. He died at age 39 of respiratory failure. We know that he had liver disease from the stigmata that he demonstrated. He had episodes of GI bleeding or of vomiting blood. He was frail and small. He had peripheral edema. He lacked facial hair, the estrogenizing effects of cirrhosis. He had lung disease in the sense that he had episodes of hemoptysis. He was barrel-chested, although this preceded spirometry. I'll show you in a caricature of Chopin at age 34, 5 years before his death, that we could agree that he was barrel-chested. He was said to have recurrent respiratory tract infections, perhaps on the basis of bronchiectasis. And although primary records of his postmortem have been lost, it's known from secondary records that he neither had cystic fibrosis nor tuberculosis, two conditions that could also cause liver and lung disease, of course. Furthermore, he was known not to be clubbed, to have digital clubbing, which would be expected in an adult with cystic fibrosis. And I'll show you a death cast of his hand, as was often done for famous pianists, and we can appreciate that he was not clubbed. Furthermore, you take a family history and realize that Chopin had a younger sister, Amelia, who died at the early age of 14. She was said to have had GI bleeding and asthma, again, liver and lung disease in 2 generations. Probably Chopin was the first individual to be unrecognized with alpha-1, having died 114 years in 1849 before the first description of the disease by Laurel and Erickson in 1963. This is Chopin at age 35. I think we could agree rather barrel-chested, and this is the death cast of his hand. And while we can't bellot his nail beds and appreciate the sponginess, I think we could agree that he's not at least blatantly clubbed, arguing against cystic fibrosis. So, in closing, let me suggest that all symptomatic adults with fixed airflow obstruction should be tested for alpha-1 antitrypsin deficiency. This is consistent with the guidelines. 2, that the radiographic features of deficiency include lower lobe predominance, which is present in about 2/3 of such patients, but not universally, and a high prevalence, about 95% radiographically of bronchiectasis, only 27% in PARS series of whom have symptomatic bronchiectasis. That augmentation therapy is the infusion of pooled human plasma alpha-1 that's derived from plasma and purified, and that the evidence that suggests that augmentation therapy has efficacy, although definitive trials are not available, largely because of the challenge of studying relatively uncommon diseases in large enough numbers. That novel approaches to treating alpha-1 are clearly under investigation and, in my view, are coming to fruition on a near-term basis and will change the complexion of our practice, hence emphasizing the importance of recognizing these individuals, which hopefully we'll all do. With that said, let me thank you for your attention. Again, my name is Jamie Stoller. I'm delighted to present this material. I hope you found it helpful for your practice. Thank you.